interventions that are going to have impacts on patients, communities, systems, funders, and so forth, it's very important to have stakeholder input at the beginning of the process. Search multiple databases. Certainly, you want to get the entire universe of evidence, not just the things that you agree with or are more likely to be published in journals that are indexed in Index Medicus, for example. You want to follow a documented, transparent process. You want to rigorously evaluate the evidence, and then, despite all of the subjectivity in this whole process, you want to do your best to at least minimize that subjectivity. And then here's another use of bias, which is somewhat different from the other. You want to avoid individual biases about what the truth is. And as we all know, experts are the worst. Experts, the older you get, the stronger your biases get. So just to review the process, you refine the key questions to develop some sort of sense of what your analytic framework is going to be, do a comprehensive search, screen studies based on that specific inclusion criteria, extract data from the studies. I think this is probably a misnomer. Data does not equate to evidence. You construct evidence tables based on your synthesis and assess the quality. Here's quality is sort of like, it is in the eye of the beholder, and risk of bias is one aspect of quality. The problem with all of these very carefully constructed multi-dimensional sort of assessors is we often have to do some overall assessment of quality, and it's not at all clear how to do that. Finally, and we're only going to just touch on this, in many cases, you have to somehow synthesize the data so that it begins to look like evidence. And think about things like applicability. Much of this can and should be qualitative, and then there are many quantitative methods, but it's quite easy to generate pages and pages and pages of forest plots that really would have benefited from some pretty careful attention to the qualitative issues involved. And then this overall strength of evidence, I alluded to it, but it's some gamish of risk of bias, precision, applicability, directness, and it's a fairly technical term. And then you have to report it in some way that makes sense and is reliable, and it has to be useful to the end user. Pretty tall order overall. When you start to get into this, you'll find variations. So there are purely qualitative syntheses, and qualitative research is its own thing, and there are semi-quantitative, very detailed sort of model ways of doing qualitative syntheses that are particularly relevant to complex interventions. And people who are doing behavior change or behavioral health interventions, the interventions themselves are never simple, and even medical interventions are always highly dependent upon sort of patient education and so forth. So I think it's become clear to me that much more emphasis on the qualitative end before you start to do quantitative synthesis. And then there are these sort of subsets. So there are reviews published where there's no evidence at all. It's just like, here's the evidence map. Here's where I think the evidence exists. And now, now I'm going to go to the next step. There's this idea of living evidence synthesis, and you spend a year of your life, do this huge review. It's published, and within months, there are 10 new studies in the area, sometimes landmark studies. How do you leverage that hard work that you spent a year at and make it useful 5 years from now? And then sort of conversely, like during COVID, there was a need for people to make decisions about things like masks. So there were rapid reviews, which almost by definition have to take some, have to skip some steps or be done faster. And then, believe it or not, there are overviews. So there are systematic reviews of systematic reviews. And then my own particular obsession, which I have not really, I've only been successful in very specific instances, is this issue of analytic reproducibility. Given the evidence, that data that you've extracted, is it consistent and clear how you get to the graphs and the conclusions that you've made? There are some groups that are have been working for decades and have very well established processes. One is the Cochrane collaboration. I think people are familiar with Cochrane. There's a very useful Cochrane handbook. Cochrane tends to have, at least historically and currently, a large, heavy reliance on randomized controlled trials. So it's not infrequent to see these Cochrane reviews that find 2 relevant trials. Nonetheless, the methods are well described in infinite detail and very important contributors. NICE, the UK-based group, also does really good systematic reviews, and it comes with some teeth, right? Because they do what the US doesn't do, and they do cost effectiveness analyses and actually use it to determine what gets paid for. So some examples of, and I, as I've sort of done this, I think there are some things that are generally useful that have come from these people who have gnawed away at evidence synthesis for decades. One is the Prospective Registry of Systematic Reviews. This is a Prospero group that I mentioned. You can search it. You can find other people who have attempted to do the same thing in the past and who are in the process of doing things. You can look, if you're detail-oriented and critical, you can look at a published systematic review and see if they did what they said they would do. Did they have protocol adjustments? I would just mention that it's quite challenging to, unlike a clinical trial where you have control of your interventions and your outcomes to a great extent, that we do this exercise of defining the, everything, and we'll talk about defining, and then you're stuck with what you have, and it never quite fits. So here there was an introduction to the PICO or PICOTS formulation. So important things to think about are what population are you interested in generally? And for pediatricians, age is always problematic because particularly around adolescence and the definition of adult. And so we did a review of substance use treatment, and one of the difficult groups to get at was this, was the 21 to 26-year-olds, the so-called emerging adults, because trials are expensive, labor intensive, and it's quite unusual for them to report subgroup analyses of 21 to 26-year-olds. And so there are some very important populations that get lumped in with adults in general. Intervention. So was there a drug or a behavioral intervention? And then diagnostic tests can be thought of as interventions. As with the coffee example, it's quite important to think about what the comparators are, because at one level, evidence is a contrast. It's a comparison of 2 things, and comparing somebody with an active intervention with people on a waiting list is quite different from comparing an active intervention with somebody taking a placebo. Outcomes we'll talk a little bit about. That could be a whole, seminar. There are many choices and many ways outcomes are presented. And often for trials, we don't have the outcomes we really want. We have intermediate outcomes, but we don't have really the things that are important to patients, like quality of life or years of quality survival and so forth. We have proxies. The timing, I'm just finishing a review of treatment of preeclampsia, and we got into the great difficulty talking about sort of the antepartum period, the peripartum period, the early postpartum period, the late postpartum period. And studies are done at convenient times. So when you have individuals hostage right prior to birth, you may have more data, but the information you're really looking at, you're really interested in is, what was their blood pressure a week later. And then infinite details with study design and setting. So, I thought this borrowed picture was quite interesting. This was actually, these piles were used at Tufts by the group that preceded, that eventually moved to Brown. This was in 1999, so not ancient history. And these were the citations with abstracts that were reviewed by hand by the research team. Fast forward to today, this abstract is a homegrown product developed by the group at Brown, where you're presented with a web page, and you click green for accept, red for don't accept, and it automatically assigns at least 2 reviewers to each abstract. And then you can identify where you have discrepancies or questions and go back and assign, keep this abstract in, keep it out. And the state of the art is that if you do a comprehensive search, you get a lot of things. It's very non-specific. You get a lot of things that get excluded. But remember, this generates tens of thousands of abstracts. So the beauty of this tool and others is that it can learn from the behavior of trained abstract reviewers, and some of this can be done by an algorithm. There are infinite data extraction issues. Sometimes it's just downright confusing. You can't figure out what the authors are doing. Sometimes their report this, there are clearly errors, and a common one is they report standard error instead of standard deviation. Outcomes are often continuous, but they're dichotomized for reporting. So there are many issues. We're just talking about this responder analysis. So you have this beautiful scale that has, multiple dimensions, and then somebody, usually sort of ad hoc, defines a response and then dichotomizes it. Sometimes means only are presented. It's very common to have standard deviations for individual groups, but no correlation between the 2 groups. Discrepant data, different parts of the same report get different numbers. Very common to have data in graphs that, and fortunately there are tools that you can actually copy the graph from the paper and then extract sometimes individual data points, or certainly means and standard errors or standard deviations. Sometimes the conclusion only is reported, or in certain literatures, only coefficients from models, which at least to me are poorly described. And then, very effective research groups publish a lot, and they often publish overlapping publications of the same study, where it's quite difficult to know if the same patients were included in multiple publications. A little bit of talk about metrics. We often think about 2x2 tables. It's in the classical parallel group randomized trials. There's a treatment and a control, or 2 active treatments. And then the sort of rate of some dichotomous outcome is expressed. But even within that, one can do it as an odds ratio, and there are methodologic reasons to prefer odds ratios, but patients often think in terms of risk differences. People often conflate the odds ratio with the risk ratio, which is only really true for rare events. Lots of details with even dichotomous outcomes. Same issues for proportion of events in a study, so number of deaths, for example, with the rare outcome. Again, same issues. Oftentimes for methodologic reasons, these are symmetrical only on the log scale, but people who understand them, it's quite easy to get lost in the details of log transformations, just differences of logs, and you're still stuck with the need to explain it in English. I much prefer continuous outcomes, and there are well-described methods for things like mean differences, which implies the difference in the means at the end of follow-up. Sometimes a sort of difference in difference estimate is useful, so, and I'll show pictures here. So in many cases, you sort of have a pre and a post measurement. The mean difference ignores the pre measurements and compares the post. So it's a change. So for example, a difference in FEV1 after some asthma treatment at the time of discharge is, and at least it has units like. So that would be an example of a mean difference. A net difference is sort of you calculate the within arm change pre to post in both groups, and then you look at the net difference. And then in literatures where there's often the need to combine related effects measured on different scales, that of course happens in education and social science, people get into using these dimensionless metrics, which rely on standardizing the change based on the standard deviation of the measuring instrument. They're frequently criticized, but sometimes the only available option. So I wanted to just kind of talk briefly about meta-analysis. I'll try to present a second talk on quantitative synthesis, but basically the idea is that you squint, depending on the goal, you sort of squint and you say, I'm going to compare things that sort of that address the same question or intervention that are kind of clinically and methodologically similar, but this process is inherently subjective. So it has potential advantages. You can, and I'll show some brief examples. You can improve the precision of sort of your of the evidence. You can identify whether the evidence is heterogeneous across studies. You might be able to explain the heterogeneity. It does force you to look at the data rigorously. You might be able to make predictions, and you might be able to detect and attempt to correct bias. We'll talk about a few examples of that. Here are some old famous meta-analyses from the days of the giants about things that I don't know much about. This was beta blockers for secondary prevention of myocardial infarction. It's an example of increasing the precision. So if you sort of, clearly there was lots of heterogeneity at some level among all of these studies. The outcome metric was an odds ratio. And this is sort of an odds ratio of 1. So to the left of the line, this was a useful effect. And to the right of the line, this would be a harmful effect in this case. And there was, small studies that gave imprecise estimates. But at the end, if you believe all of the assumptions that go into it, you can get an overall estimate that's quite precise. Now, it may be biased, and you get a sense of the heterogeneity, and you might be interested, for example, in understanding some of these trials that seem to suggest the opposite. Let's see, yeah, so this was, I thought, a fascinating study. You know, sometimes to change behaviors, it takes a mega trial, and at least in this case of thrombolytics for acute myocardial infarction, and, you know, not ancient history, practice didn't change until till long after a cumulative meta-analysis, which sort of presented the evidence as it was obtained, gave fairly precise evidence that that treatment was effective. So it may be quite useful. Meta-analysis may be quite useful if you have similar trials of, you know, really answering the question without the need for a huge mega trial. So this is, I had the pleasure of working briefly with Joseph Lau, who was the you know, one of the giants in this area, and his famous quote was, "Nobody's going to criticize you for doing a systematic review, but as soon as you begin to combine data, you'll get disagreements." And they come in sort of various flavors. There's the apples and oranges question. You know, if you look with a powerful enough lens, all trials are very different one from the other. If you combine a lot of garbage, you're going to get garbage out. In many cases, you're stuck with what they report. So you know, you have this beautiful network of comparative studies with 30 studies, and then, oops, only 5 of them reported in anything that I can combine quantitatively. So you lose data, and you may lose data in a biased way. Selection of studies: do you combine randomized controlled trials with non-randomized comparative trials? Talk just briefly about publication bias. And then in the weeds, there are assumptions, and those can get you into trouble. So this was a nice illustration of a sort of a landmark paper showing that over time, the research community has gotten better. So these were relative risk of a primary outcome. So this was an effect. These dots below this line indicate effective interventions. These are interventions that are kind of, you know, probably similar, and these are actually harmful interventions. And over time, for reasons that I'll talk about a few of them, it appeared that there were missing studies, or at least there was bias toward effectiveness. And then as the trials have gotten larger and presumably better, many more interventions, and probably the interventions are much more nuanced, and, you know, the things that were going to work, you know, epinephrine for anaphylaxis, you know, those are not the interesting questions these days. I think it's really interesting that a lot of the things that have probably improved research overall had to do with sort of these structural changes. So pre-registration of trials. So there's clinicaltrials.gov, and then there are various international clinical trials registry, where people are forced to get, for an individual trial, to pre-specify the question, the outcomes, the patients, so forth. And then there has been a proliferation of these, and the Equator Network puts them all together. Consort and its extensions for randomized controlled trials, but I would encourage anybody who is doing anything as small as a case report, a systematic review, to go back and look at this and look at these reporting guidelines, because they've often been done by people who have been stuck trying to extract studies. And I can't tell you how useful consort is, for example, when you're trying to figure out what patient, where the patients that are, where the outcomes reported, what subset of the included randomized patients did they include. Looking at some of the older literature pre-consort, it's just really very challenging. So, heterogeneity is another area where it's another one of those overloaded terms. Ultimately, it's a subjective question. Are the studies and effects sufficiently similar? How similar are these fruits? Are average effects appropriate? There's clinical heterogeneity, and then there's sort of statistical heterogeneity, and they interact. And this gets into some of the details. You can ignore it and sort of pretend that there's an effect that's consistent across all studies. You can estimate it, but it's sort of like trying to estimate, it's sort of like trying to test for normality. Not very useful. You can try to account for heterogeneity by allowing for study effects to vary across studies. And finally, if you have, and this is rare in medicine, you can do subgroup analyses or meta-regression, but you're stuck, as long as you're stuck with aggregate data, there are significant limitations to that. Anyway, sort of a brief attempt to talk about a lot, but I think in part it's, it's not, evidence synthesis is a team effort, and it's a process not unlike designing a clinical trial, and lots of opportunities for improvement and asking questions of real experts. Anyway, I'll stop there. I'm not sure how I've done on time, but happy to address any questions.
Well, thank you so much, Dale. That was awesome, and a great overview. And let me, if anyone has a question, they can either raise their hand and ask it or put it in the chat. I'll just wait a moment to see if anyone has any questions. While people are putting stuff in there, or putting stuff out there, I have a couple questions. The first is the Abstractor tool or software that you said it's homegrown and through Brown. Is that available only to your center? Is that commercially available? Because I would think that would be useful for individuals who are embarking on doing systematic reviews.
Yeah, so there are competitors that are commercially available. The Abstractor is available for anyone to use. And if you find yourself attempting to do a systematic review, it has the advantage of being free. And but the disadvantage of sort of changing frequently and not having a sort of level of documentation that you might have from something you pay thousands of dollars for. I will tell you that that's just the first step. So you start with this metaphorical huge pile of abstracts, and then you end up pulling and trying to do a second level of screening at the level of full text. And there are many decisions to be made. One of the common ones is, do you accept conference abstracts, for example? Do you accept English language only, or do you use Google Translate to translate Turkish or Chinese, Mandarin? So lots of, and then you winnow it down to papers that you then extract. There's a related tool that's called SRDR that's funded by AHRQ, and there are many other tools. I think in practice, and I believe the Cochrane Group also has a tool that's quite challenging, right? Because unlike a trial where you have a sort of a database of outcomes, you have you can't predict until you see a trial what outcomes and how they're going to be presented. So you have to be, so you sort of, it's sort of this iterative process. So yeah, there are multiple tools, and it's actually an interest of mine because there are groups who are trying to generate open source tools that are usable for everyone. And then obviously lots of issues with deduplication, so all of these, you find an abstract or a paper in Embase, and there's about a 9 out of 10 chance that it's also indexed in PubMed, but you, for whatever reason, didn't find it in PubMed, and so you need to sort of have common identifiers. It's this huge organizational challenge, which clearly there are many opportunities for sort of software tools.
That's great. Thanks. Does anyone else have any questions?
I had a question, but I don't want to take up the time. But other people have a question.
I have one quick question. Hopefully there's no wind in the background. I'm trying to listen to you and learn while I get some fresh air, Dale. Is there a process by which we can set up a consultation to discuss whether or not our topic is amenable to something like a systematic review or meta-analysis? And I'm thinking about, I'm focused on child abuse, abusive fractures, and use of artificial intelligence to identify abusive injuries. And so the literature there is broad, and speaking to some of your points is varied in its quality and study design. So if it's a possibility to sort of make a formal consultation to discuss.
So for you, it's easy. Just email
Do I
me.
just bring you coffee and don't let you leave until I...
And bring me Dunkin' Donuts, coffee, and then I think that the challenge is to sometimes really define the questions so that they're doable, and then identify the people who can help you. I know some of those people, and I can point you to the Cochrane Handbook, for example, is a very good starting point for sort of some of these basic steps. But yeah, I think it's a little daunting to think about it at the outset. And but yeah, certainly happy to talk.
Awesome, I'll hold you to that. Thanks, Dale.
All right, one last question. Tom, do you want to ask yours?
So first a comment, when you were talking about, well, is death really an outcome, and what is death? I couldn't help think of the Monty Python Life of Brian scene, do you have to be fully dead? Anyway, sorry, that I couldn't resist. I was really intrigued by your comment about evidence and quality of evidence, and how hard it is to do a study that really has high quality evidence where you've really looked at all the different factors. So I'll pick a mental health one, but I can think of an injury prevention one too. One of the big criticisms of a lot of psychopharmacologic studies are they take this pure population of depression only, and if you have anything else, you're excluded. Well, that's so much of the population. So you excluded this big chunk of the population. And so now you have evidence, but who does it really apply to? And how does it really relate to the real world? But even in injury prevention, I think that there's so many layers, there's so many factors when you're trying to figure out how do you tease that apart. So any thoughts or any advice on how do you get good quality evidence? Design a study so that you get good quality evidence.
Yeah, you asked a really deep and difficult question. And I think there is because we talk a lot in, like when you take statistics classes, you think about random samples. But I think the first really germane point to be made that you made is that the people who are included in trials are in no sense a random or representative sample. It has the huge advantage of the randomization process allows you to sort of across the study have random allocation of unknown confounders. You can adjust for known confounders, and probably the power of, and then you're looking at a difference, right? And there are many ways of expressing that difference. So for some interventions, and we've just been thinking about obsessive compulsive disorder and a particular brand of cognitive behavioral therapy. There's this sort of umbrella, and it's becomes quite clear from these small but very well designed trials that there is an effect. But then the question is, how transportable is it? What are the predictors of effects? So things like age or comorbidities, or and then what are the moderators of effects? And for example, race and ethnicity, there's been an appropriate large amount of attention paid, but do the so for in certain groups, is the intervention more or less effective? And trials are powered. I've heard costs of $60,000-$70,000 per patient for some of these trials. They're powered for overall effects, and I think that there's a lot of snake oil in terms of individualized prediction, precision medicine, and so forth. I think we're expecting a lot of algorithms and data, and so in one sense, I think that the overall sort of transportability of conclusions from well done randomized trials is probably underestimated, and then we probably overestimate our ability to look at effects, the predicted effects of a given intervention in a person. And it's, this is something where there are a lot of smart people who say a lot of things that I try to read and I don't understand them at a deep level, and I think it's evolving. But yeah, clearly very important.
I knew it was a hard question, but I figured you'd give us the answer. So there you go.
Yes, we got it. We got it in. And so with that, thank you so much again, Dale Steele, Dr. Dale Steele, for your presentation. If you could please just quickly complete this poll about how helpful today's presentation was. And we do have another presentation today at 2 p.m. Dr. Dorothy Espelage will be talking about bullying as a developmental precursor to sexual and dating violence across adolescence. And these recordings will be available on the COBRE website. So please spread the word, and we hope to see you again. And thanks again to Dr. Steele. Take care, everyone. Bye-bye.